The ECG. It's an absolute cornerstone of modern medicine, right? But you know what? It's also a breeding ground for myths. These ideas that get so ingrained, they're just passed down from one generation of clinicians to the next. In this explainer, we're going to tackle 3 of the biggest and most dangerous ones.
And as we go through them, I really want you to ask yourself this question. And be honest, because the goal here isn't just to memorize some facts, it's to actually challenge the very foundation of what we think we know so we can all get a little better at what we do.
You see, the most dangerous myths aren't the ones born from complete fiction. They start with a kernel of truth. They're usually simple rules, designed to keep patients safe. But, as we're about to see, when you oversimplify things, it can become just as dangerous as not knowing anything at all.
All right, first up, the absolute dogma around wide complex tachycardia.
Come on, we've all heard this one. It's drilled into us from day one. See a fast, wide rhythm? You treat it as VT until proven otherwise. And look, from a safety point of view, that's pretty good advice. But as a diagnostic rule, it's actually terrible.
Let's just look at the numbers. Yeah, it's true that in older patients, especially those with heart disease, VT is the cause about 75% of the time. But that still leaves a massive 25% that's something else entirely. A 1 in 4 chance of being wrong? That is a risk we really can't afford to just ignore.
So what's hiding in that other 25%? Well, the most common culprit is usually SVT with aberrancy, basically a fast rhythm from up top that just looks wide. But it could also be something much more sinister, like antidromic AVRT in a patient with WPW, or even something totally non-cardiac, like severe hyperkalemia or a drug overdose. The point is, your clinical context is king.
So here's the real rule, the one we should all be using. Sure, treat it as VT when you're in doubt. That's safe. But never, ever stop thinking. That wide QRS isn't the end of your diagnostic process. It's the very beginning. You have to look at the morphology and, most importantly, the patient right in front of you. Okay, myth number 2. This one has to do with the absolute gold standard for diagnosing a heart attack, the 12-lead ECG. The thinking kind of goes like this. If the 12-lead is the definitive test, then you must need the whole thing to make the call. But in the emergency world, believing this can lead to absolutely critical delays in care. The reality is all about making a key distinction between 2 very different actions, suspicion and documentation. To formally document an MI for the chart, yeah, of course, you need the full 12-lead printout. But to suspect a major coronary occlusion and to get life-saving treatment started, that often takes just a few seconds and a few leads.
Just think about a paramedic looking at a 3-lead monitor in the field. They can spot a massive anterior STEMI just looking at V1 to V3. They can see an inferior MI with leads I, 3, and AVF. These critical patterns, like de-Winter T waves or huge hyperacute T waves, they can all show up long before the full ECG is even done printing. Waiting for the paper can literally mean losing precious heart muscle.
This is the real rule, and it is a total game changer. We have to empower ourselves and our teams to act on suspicion. Get the cath lab on the phone. The paperwork can catch up later.
All right, our final myth. This one is maybe the most subtle, but it's everywhere. The meaning of ST depression. I mean, this is ECG 101, isn't it? It's one of the first patterns we all learn. You see ST depression, you think subendocardial ischemia. It's clean, it's simple, pattern recognition. And it's also dangerously incomplete.
The truth is, ST depression is one of the least specific findings on an ECG. The list of things that can mimic it is so long. You've got meds like digoxin, electrolyte problems like low potassium, even just a fast heart rate or structural issues like LVH with strain. I mean, the list just goes on and on.
But listen up, because this is the single biggest trap. If you see ST depression in leads V1 through V4, your brain should not be thinking subendocardial ischemia. It should be screaming posterior MI. What you're seeing isn't ischemia in the front. You're seeing a mirror image of a full-blown ST elevation heart attack happening in the back. That's an occlusion, and that patient needs the cath lab right away. So the crucial point here is that ST depression is a clue. It's a starting point for your analysis, not the final answer. You have to ask, where is it? What's happening in the other leads? And what does the patient look like? The context and the overall pattern are everything. So we've just debunked 3 pretty big myths. But why does moving past these simple little rules matter so much? Because the clinical stakes are incredibly high.
Getting this stuff wrong means giving a dangerous drug for the wrong tachycardia, delaying opening up a clogged artery for a heart attack, or sending a patient for a totally unnecessary procedure. These are not just academic exercises. They have huge, real-world consequences for our patients.
And this really gets to the core of it all. We learn rules to build a foundation, but real clinical excellence, being truly great at this, means knowing when to break those rules. It's about understanding the deep physiology, embracing the nuance, and knowing not just why a rule works, but more importantly, when it's going to fail you.
So I'll just leave you with this one final thought. We've challenged 3 big myths today, but our practices are filled with them. So what piece of clinical dogma, what rule you follow without even thinking about it, will you take a closer look at tomorrow? Because that continuous curiosity, that's what truly defines an expert.